Okay, welcome back everyone. A warm welcome to all our panelists. From the left, you can see on your screen, Dr. Nabilah, Dr. Azrin, Dr. Amir, Dr. Shamala, and Dr. Rabithoh. Okay, so we already have some questions given to us, so we shall start our Q&A session now. Okay, the first question is supra-inguinal approach superior to infra-inguinal approach, and why? Maybe Dr. Azrin can answer this.
Okay, the answer to that question is there's a definite superiority regards to supra-inguinal fascial approach compared to infra-inguinal, because it's the spread of the local anesthetic is more cranial. So when with the technique itself, your injection direction is from caudal to cranial. So as you inject, the force of as it spread is going more proximally. And the other thing is that looking at the sonor anatomy, you can see that actually the position of the iliacus muscle itself is if you inject, then you follow gravity and spreads more cranially, and you expect the local to spread as high up as to the lumbar plexus. But that will depend on the volume and the speed of injection. So on the other hand, the infra-inguinal technique, it is actually from a lateral to medial direction. So it is basically just around the area of the inguinal tubes. So that's why it is it's proven on caliber studies that if you perform the supra-inguinal technique, the spread will be more proximal, more cranial, and hence result in a larger area of spread.
Okay, thank you, Dr. Azrin. Okay, the next question from Amir Azwan Azman. What is your comment regarding usage of dextrose 5% versus normal saline for the dilution of LA? Maybe Dr. Nabilah can answer this.
In what I've been practiced is that I've been diluting my LA in the normal saline. But then if we want to locate, like when we are doing our scouting, like we want to see where's our tip of needle at, then we might we can use either D5 or normal saline. But in my practice is I only use normal saline to dilute the LA.
Okay, thank you, Dr. Nabilah. Next question from Pediatric Anesthesia Hospital Kuala Lumpur. Well done, organizing committee. Okay, so their question is, I wonder, how do you find difficulty in needle visualization in ESP block? Is a frequent problem, and how to overcome this? Dr. Shah can address this, or Dr. Amir?
Sorry, such a long question.
Can you see?
It's a frequent problem and how to overcome. Okay, problem with needle visualization is not only specific to ESP. Okay, it occurs in all type of block because the main problem is the ultrasound wave does not cut the needle at the exact location. So to answer this, how to overcome, we need more practice. Any tips? You really have to look. We really have to look at the insertion point and the position of the transducer. Okay. My general tips will be, what usually happen is a lot of time you get a nice sonor anatomy, but you lose the needle. Okay, so try to scan and try to get the needle in your screen and then judge the movement of the probe from the nice sonoanatomy, from the nice sonoanatomy to get the nice needle view. Okay, I hope you got it, what I mean, because it's very difficult for me to just explain. It's easier for me to show. Okay, so what and see from the sonoanatomy to the needle view, what movement, transducer movement you have made that give a nice picture. So you probably have to realign your needle according to the movement of the transducer. I hope I don't confuse you more.
Can I just add a bit? I think it is whether it's to just to familiarize with the plane of the ultrasound probe. Most times, especially when patients are in lateral decubitus position, the probe tend to slide out from the probe easily, out of plane easily. So that's why when you perform the block in lateral decubitus position with the gel, then naturally it falls following the weight, and you tend to slide away from the needle pathway. So that's why most times you tend to miss and can't see the needle. Maybe there's a tool where you can actually align, make sure that your needle is aligned with the probe, and you have to. I don't know whether it's available in the market in Malaysia. It is an applicator where you would click to the probe, and it ensures that the needle is aligned with the probe. But then it is with a fixed angle, so you can't really maneuver. So you don't have the flexibility of changing direction. So I guess that is one way of how you can increase your success rates. But I guess with that, it limits your flexibility, so that it will be the drawback. So I hope that also helps to answer the question.
Okay, thank you, Dr. Azrin. Dr. Amir. Next question. When do we perform both supraclavicular plus axillary or musculocutaneous for upper limb surgery? How much the axillary mil should give in this condition? Yeah, I think she meant she or he meant how much the axillary volume should give in this condition.
This question itself is a bit, I'm not so clear, because when you are performing the supraclavicular and also axillary, you are actually aiming the same brachial plexus. We are aiming the same nerve. So I'm not sure why we need to do both for a patient. So most of the time, we only use we perform supraclavicular if we are aiming to do the operation or to do any kind of procedure, like from the shoulder below. But then if the procedure is more distally, like below elbow, then axillary is surface. So I don't think there is any kind of indication that we need to do both. So about the volume, how much volume that we need to give for the axillary approach, plus the musculocutaneous nerve, 20 mils should be enough, meaning that regardless of what kind of technique that we are aiming for, meaning that are we aiming for the LA surrounding the axillary artery, or are we aiming for the respective nerve? 20 mils, like if we are aiming for the respective nerve, we can give 5 mils for each nerve. meaning that 5 mils for the radial nerve, the ulnar nerve, the medial nerve, and also the 5 mils at the musculocutaneous nerve. 20 mils is enough. Supracapitular is also the same thing. 20 mils is enough. But then we have to remember that we are doing under ultrasound guidance, real time. So we can actually see the real-time disposition of the LA. So if we think that 15 mils is enough, the nerve is well covered, and 15 mils is enough.
Okay, thank you, Dr. Nabilah. Okay, the next question.
Can I
Sorry,
just
Dr. Azrin, yes.
I think the only time probably that I would expect to have this scenario is when you have performed a supraclavicular approach, but you find that it doesn't cover the ulnar side. Either you need to wait further for maybe half an hour for the local to spread surrounding the or going towards the inferior trunk, or you would do an selective auxiliary approach to just cover the side that is not covered, which is also not covered, probably the radial or the ulnar side. So I will expect to have this scenario as having auxiliary approach as a rescue technique when a supraclavicular block approach failed or it was partially working. I think that would probably be the only scenario. And how much would you administer depends on what has been administered before. If you have given 20 mils of a more concentrated solution, then I would probably limit my volume towards what Dr. Nabilah mentioned, maybe 3 to 5 mils of the selective block. So probably there is one scenario that I can think of where you need to give auxiliary on top of a supraclavicular.
I can't think of any surgery that you have to block from C5 till T1. Okay, blocking supraclavicular, mainly you are targeting, I would say C5, 7. If you are careful and block at the corner pocket, you probably can get C8, T1 as well, but probably sometimes about 20% you can miss that route. Okay, so I've never done a double block. Block at the supra and axillary stroke musculocutaneous, because I don't find any usage the benefits of doing that. What I usually do, if let's say I tend to do supraclavicular block in a distal upper limb surgery, I will try to target the local spread at the corner pocket, which is at the area of C8, T1, okay, or 7, 8. And if it's a arm surgery or shoulder surgery, I just block at the upper part of the supraclavicular brachial plexus. Where the C5, 6 roots are there. So about the volume, I probably agree with the other two of my colleagues. So I'm really not sure why you have to do a double brachial plexus block.
Thank you, Dr. Ami, Dr. Azrin, and Dr. Nabilah. So the next question will be directed to Dr. Shamala. Where do you see ultrasound-guided regional anesthesia going in the next 5 years, particularly in the emergency department?
All right. Okay. So ultrasound-guided regional anesthesia, I think the emergency department, we are still at the infancy stage, very new, but it has a very vast interest. There are a lot of emergency physicians, emergency departments that are actually incorporating it in their daily practice. So we in EDHKL, we have a projection. We are trying to be an accredited center maybe in the next 5 years. So we hope with like more trained emergency practitioners, we can incorporate ultrasound guided regional anesthesia as a modality of pain management, hoping it's nationwide. It can be practiced in every emergency department ultimately in the country. So we are looking at this in the long term. We hope that we can produce more publications, more scholarly work, maybe participate even in more on an international platform. Yeah, we have big dreams, big hopes. Yeah, starting small, but we hope to get that. Yeah.
Okay, thank you, Dr. Shah. Next question for Dr. Rabithoh. Have you encountered any regional anesthesia complications in the emergency department, and how do you manage it?
We talk in the view of emergency department. Alhamdulillah, actually, we do have approximately about 120 cases since I think last year in ED. So Alhamdulillah, we never encountered any major complication like local anesthetic systemic toxicity or pneumothorax, or any major severe nerve injury. But we do have a pathway, like I mentioned before, if we encounter such of the complications. So it is important for us to observe, to monitor, and to follow up patient for each block that we do.
Okay. Thank you, Dr. Rabithoh.
Can I add?
Yes, please.
I think the incidence of peripheral, nerve injury is very small. So after 120 cases, you probably won't get. Means we have not done enough. So I'm not asking, I'm not hoping for any nerve injury, but somehow along the line, usually it will happen. So especially after you have reached thousands of cases, so you might encounter complications. So be prepared.
Thank you, Dr. Amir, Dr. Rabithoh. So we have to do more, yeah? Okay, next question by Wazin. Is it safe to discharge patient from emergency department before the anesthesia wears off? What's the discharge criteria? Maybe Dr. Sham can answer this.
Okay, so we have a protocol in place. When we perform RA, we observe the patient in our trauma bed for at least 1 to 4 hours. So we assess our patient, we make sure there's no immediate complication, and all these patients that are discharged are actually under our follow-up. So we, on the next day, we have a designated team member that we will call up the, usually it's a teleconsultation, and we will ask the patient whether the patient has any particular symptoms to elicit any possible complications. So we are also advised the patient upon a discharge, we have a little memo sort with complications that the patient should anticipate. So the patient is already notified on the possible symptoms they might have, they might encounter, and to come back to us immediately if they do encounter any of the signs of complications. So we also have another modality, which is our EM watch, which we are hoping to incorporate, whereby we can actually visualize the patient. It's like your a video call, so we can actually see these patients, and then we can talk to them. We can see whether they have any sort of complications, and we can advise them accordingly. So yeah, that's what we are doing now, and that's the future practice we hope to incorporate. Yeah.
Thank you, Dr. Shamala. Okay, next question. In your experience, have you encountered anaphylaxis after administration of LA, and how do you manage if such incident happens? Okay, anyone would like to address this?
I think Allergic. Allergic to local anesthetic thing is very rare. I've not encountered any anaphylaxis towards local anesthetic, and I hope it won't happen. Okay, because that's our cari makan. So we are working patients. So basically, I think local anesthetic is a very safe drug. As long as you take all the precautions, avoid the intravascular, inadvertent intravascular LA injection. Okay. I think it will be quite safe.
Just to add a bit, I think with the drugs, with the choices of drugs that we use, I think it is safe. It said that anaphylaxis tends to occur with the extra groups of LA. So we are commonly using the amide. So we are basically quite safe there. Depends on what you're using. If it is lignocaine, then you have to be aware of the doses of the doses. So I guess not with regards to anaphylaxis, but more towards last the complications, if any were to occur.
Okay, thank you, Dr. Ami, Dr. Azrin. Okay, next question. In emergency department, we will normally use ropivacaine, which is known to have a shorter duration of effects. So is there a way to prolong the effects and the duration of this particular block using, in addition to ropivacaine?
I think ropivacaine is considered have a longer duration of action as compared to lignocaine. So have to see what kind of procedure that we are using the LA. Like, let's say if we are only used for CMR, we don't need the anesthesia to last like for 24 hours. Okay, because we only need it for procedure. Like let's say for a rib fracture, and if a patient is admitted to the ward, then it's easy. We just insert a catheter in and then give a bolus, multiple bolus or infusion. But there are a lot of ways to prolong the LA, which is quite famous. One of it is like adding a IV dexamethasone, or we give intraneural dexamethasone, meaning that we mix the dexamethasone with the LA, or we can also mix clonidine. But this is my own practice. I never add any kind of things to my LA, but I do practice giving IV dexamethasone with my LA. There's a lot of other things like dexmedetomidine, which is Presidex, that they add on the LA. And to know whether it's actually really prolong it or not, I think we need to really read all the articles and the research. Okay. And all the additive is not actually licensed to use together with the LA. So it's all unlicensed.
Okay. Just to add, I think the indications for the use of different types of LA needs to be justified. I think for procedure use, then probably you need something that is short acting, short duration. Short onset and short duration. But for procedures or interventions that need, or the disease itself that needs a prolonged anesthesia, then you can actually use a different type of LA. So I think the point here is probably maybe we have to experience different types of LA and maybe play around with the concentrations and the volume so that you can actually customize for what procedure and what conditions. So I guess I understand that ED has so far lignocaine and ropi 0.2%. So that's, I think this is another area where you probably need to explore use of 0.75 and try and vary the concentration and volume so that you get appropriate dosages, volumes, concentration for different types of procedures and conditions. With regards to additives, I think in our setting, we don't really use additives like adrenaline because it has some practical issues. The reason why we use adrenaline is to avoid intravascular injections. That's one of the things. And we find that the incidence of nerve injury is actually theoretically higher with the use of adrenaline or any vasopressors because it causes the blood supply to the nerves to become depleted, more ischemic because of that. So we don't really use for the population that we give nerve block. Actually, one of them are the elderly. They are comorbids. So we don't really add adrenaline. And one of them that we commonly use is dexamethasone. So probably maybe can explore the use of IV dexamethasone for to prolong the effects of block.
Okay, thank you, Dr. Azrin and Dr. Nabilah. There's a remark from Teats Anesthesia HTA. They said that they do add clonidine 1 to 2 mic per kg to regional blocks, including caudals, except for daycare. And apparently can be prolonged for as long as 12 to 18 hours, up to 24 hours. Okay, all right. Moving on, there's another question. Will there be a subspecialty of regional anesthesia in emergency medicine in the future? Shamala?
Okay, we don't, the good news is we don't have to wait for the future, it's already here. There is 3 different options. Actually, it's under the umbrella of critical care, so emergency critical care. The next is for trauma sub, or if you just want to do an area of special interest, you can pursue an area of special interest specifically for ultrasound guided regional anesthesia. So there are many options out there for anyone interested. Yeah.
Okay, thank you, Dr. Shamala. So that was the last question.
Can I ask one question?
Okay, we have a question, a live question.
Probably it's a question of maybe my failure. I did a supraretinal block once.
Dr. Alza, can you speak up?
It's like a confession session. I'm sorry, I'm not a patient, but I'm on the floor, but baju habis. That happens all the time. No, it's just that I did one supraretinal block once, and then it was well. I could visualize that it was flooded and pain-free. Patient was elderly, but subsequently BP dropped. BP of the patient dropped. So even we have to start more right. So I don't know what happened, but patient was okay lah. But patient had to be admitted. It was just a humerus fracture. So I don't know how to explain why that happened. So we thought that maybe it's anaphylaxis. So of course we give all the hydrochloric, even adrenaline. But I do not know if that is a complication that can arise. I didn't do as many as you did, but the one that I did, I have seen.
Okay, so Dr. Azrin,
could there be an explanation, or could it be something that I didn't do right, or maybe we could learn from my problem?
I mean, of course, we tend to blame any immediate procedure that we just treat the patient. Example like after a block, the patient instead of I mean the outcome is good, but suddenly the BP drop. So we tend to blame the block. But I think you have to rule out the other causes. I guess you have ruled out whether since you mentioned it was an elderly patient,
Yes.
probably cardiac causes. I'm not so sure how bad was the humerus fracture, and it bled so bad that we underestimate the blood loss.
But it was all right before the case. I mean, it was a simple fracture.
Mhm.
Patient BP was all right. Patient was about 80 years old like that. So I did the block, and then I was satisfied. It's just for observation. I went home. Then I got for BP drop after that. So
how long after the block and
probably
the hypotension?
2 hours. 2 hours, yeah.
2 hours, yeah. So unlikely is an anaphylaxis.
I think was the patient anxious?
No, cooperative. After the block, he was quite happy looking.
I think one of the most common things that we miss is actually a vagal response.
Oh, okay. Right.
So that's probably one more common reason for hypotensive episode, especially once you do a procedure, elderly, so they tend to have poor responses, the autonomic response. So one of them probably be a vagal response.
That makes sense.
But it won't be for maybe, I don't know whether that is one of the possible reasons, but 2 hours maybe a bit unlikely.
Again, after 2 hours, it's a bit unlikely.
Unless the local probably spreads proximally to the autonomic the chain. So,
Okay.
But
I can't imagine that.
again, it will probably be transient and should be able to be compensated by the non-block side. So probably multitude of reasons why, but can't really say what, and can't really definitely blame the block. Unlikely, it's unlikely because of the block. So could be a multitude of reasons.
Okay, thank you to our panelists. That concludes our Q&A session. Yes, so moving on. Thank you.